Perfect.
Am I sharing it? No.
Not yet.
Okay.
While you get your screen set up, I would just like to take a second to say on behalf of the Ontario Rett Syndrome Association of Canada's Board of Directors, we are so honored to have you here with us, Jane, and to talk to us about puberty and womanhood and all things that our girls go through, and also some males as well. I think you might touch on them. And just having your knowledge, wrapping it up just before you hit retirement, and giving us the honor of your time this evening. So thank you so much for being here. And we also like to say thank you to Acadia Pharmaceuticals, who is sponsoring our Rett Round series. So thank you guys, and we appreciate the support. Okay, Jane, you can take over from here.
Okay. Can you see I hope you can see my screen, my slides.
We can.
Okay, great. Okay. Well, it's just such a real pleasure to be here with friends, our friends from Canada, and what you've probably heard will might be my last talk before Alan, Percy, and I retire at the end of the year. I only wish that I could see you all in person. I've had the pleasure of speaking in Canada a couple of times and actually saw patients there in Ottawa one time. In a hotel room. So it's been a um, it's just a real pleasure, and I appreciate it very much. Okay, hold on. Oops. So I have my only disclosure is that I'm funded by IRSF in as a coordinator for their natural history study. So tonight we'll talk about several things. First, the stages of puberty, female puberty trends in Rett syndrome, menstrual suppression, why you would do it, and what options are there. Hormones, seizures, and medication relationships, health maintenance and GYN needs, and touching a little bit on male puberty. So let's get into class. Let's learn. So the prospect of puberty elicits all sorts of responses from family, and frankly, none of them are good ever. And this is not specific responses to families of children with Rett syndrome. And that I hear the same things and have read the same things about families with Fragile X or um, uh, um, Down syndrome, and so it's Angelman syndrome. It's universal, and why is that? Let's look at some of the reasons that it causes such fear and anxiety. Well, certainly there are new health considerations. Might there be worsening seizures? Um, how are we going to manage, or are we even going to manage menstruation and care for her in that way? Do we need another specialist for whatever gynecological health maintenance care needs to be done? Will I be able to manage her pain? I also think that there are some real misperceptions about timelines from the beginning of puberty to menarche, which is when menstruation starts. I think some families are concerned about how to manage hygiene, particularly if their daughter is in a school that's reluctant to, or a care program that's reluctant to tackle that. Although I say it's just another bodily function, and it's less offensive than some of the others that they probably deal with and do deal with daily. I think that even though any person can be abused at any point, I do think, sadly, that that's the case. I think that it is a harsh reminder that she's vulnerable and that at this point, once she um, goes through puberty and begins to have a cycle, that there is a possibility of an unwanted pregnancy. And I think that sometimes that is not considered until you're faced with that. I think that there are social taboos sometimes affecting paternal care. So, where fathers may be have been very involved in with all aspects of personal care. There's with some cultures and with just some fathers in particular, they're just not comfortable providing that intimate care anymore. Maybe not at all, or maybe just during times that she's having a cycle. And so that's something that stresses the father because he's feeling strange. It certainly stresses mothers because now she might feel, and I've heard this from families, that now she feels like everything is thrust upon her and she can't, she won't have any help. And then some families are concerned about what might be changes in behaviors where their sweet angel is now maybe a more difficult teenager. I Granted, puberty can be confusing. Um, it certainly looks like a trig problem on a blackboard at some point. It might even be scary, but it's normal. And I would almost be willing to bet that your children more than likely want to be considered just like their peers. And they don't want to be children forever. They want to grow up just like any other child there that they're going to school with, or person they're going to friend that they're going to school with. It's their rite of passage to grow up, and it's your job to be informed, positive, and calm, just like you always are when you face other things that you have to face down the road. And my goal is to try to take some of this, the mystery out of what's going on. So I see this happy dance in clinic all the time when parents think that puberty is not going to happen. You know, they're burying their head in the sand, or it's delayed, and so they think, hooray, no puberty. But to us, it's a reason to investigate, not celebrate. And that's because abnormal development could be a sign of an underlying health issue that should be investigated. And investigated by whom, you might say? Well, primary care physician is even behind the scenes is watching and asking about how development is, and it's probably placing her on a Tanner stage and asking questions about what changes you're seeing. If there is some concern about early development or late development, then there are subspecialists such as endocrinologists that can help navigate navigate the issue, investigate the issue, and see if there's really something that needs to be um, acted upon, or if it's just a wait and see. And there's an article, a journal article that I want to share with you later on that would be an important resource for you to have in your pocket in case you do have to have those discussions about ages of onset with someone who's not familiar with Rett syndrome. So this slide shows female sexual development, maturation, if you will. And let's break down what happens as someone develops and when that's supposed to happen normally. Um, Sexual development is put into categories called Tanner stages. It's Tanner stage 1 through 5, and it's um, it's determined by breast development and pubic hair development in terms of placing them in a Tanner stage um, category. There are other signs of maturation, but those are the ones that are considered in terms of Tanner stages. Development, sexual development in this continuum of Tanner staging doesn't have to be congruent. In other words, you might have Tanner 2 breast development and Tanner 3 pubic hair, or some um, combination. It's unusual, though, for there to be Tanner 1 where there's no breast development and Tanner 5 full pubic hair. So those, in our clinic at least, we'll hand them a picture just like this picture exactly, and have them parents point to what they're seeing in terms of development, so that we know how to characterize their Tanner stage. So mm, sometimes my slides don't want to advance. Sorry. So Tanner 1 is pre-puberty, so that's no breast buds, no pubic hair. Tanner 2 is when we start seeing sexual development. So breast development, which is called in technical terms thelarchy, and pubic hair growth, which is andronarchy. That's when someone is in Tanner 2. Tanner 4 is when menarche begins, or periods. And then Tanner 5 is full maturation. So these, I'm about to show you current data, current as of 15 years, 15 years ago. These are not necessarily data that are updated very frequently, but these are the averages in ages um, 15 years ago. Breast buds in North America, the averages were breast buds would develop at 9.8 years, so almost 10. Pubic hair, a little beyond 10. Again, averages from North America. And menstruation was just shy of age 13. And so I want to show, and I'm going to show in next slides, do what we see in Rett syndrome, because the misperception is that um, menarche begins much earlier than it does. In 2015, we published here at UAB, using data that our group from the consortium, NIH-funded consortium, um, wrote, looking at analyzing data from people who were enrolled in the natural history study up until that point. And it was an important paper because it updated some information from, it was a large number to begin with, and it updated data from earlier studies, and it describes some of the differences, as well as giving real ages that people could use as they were considering whether or not development was occurring as it should. So these are median ages for, as we saw it in that study, for those with Rett syndrome. So breast buds were on median age of 9.3. Pubic hair was a little earlier at in one of the first sign in most in an average number earlier than breast buds, and then menstruation at about age 13. So now let's do a side-by-side comparison. Our North American averages on the left side of the screen, Rett syndrome averages on the right. So you see, breast buds a little bit earlier than, about half a year earlier than the national North America averages. Pubic hair, quite a bit before, so 9 as opposed to 10. But look at this, menstruation, almost equal. And importantly, 4 years from the time, the first sign of maturation to the time of average menstruation. So it's not going to happen overnight. The first time you see a pubic hair, you don't have to think, oh my goodness, this is, we better go talk to the gynecologist now. You've got time to plan and prepare. Diving deeper into the natural history study data about puberty, you'll see that while almost a fourth uh, developed both pubic hair and uh, breast bud development developed prematurely compared to national norms. So 25 and 28% developed those characteristics prematurely, and a small, very small number really were delayed, but still delayed. So there's a wide range of ages. But yet, when you look at menstruation, the average age, again, median age, sorry, was 13 in Rett syndrome. Almost 19% were delayed. Only 13% occurred earlier than that age 13. So again, a wide range, but more were delayed in starting their periods than were premature. We did also some other correlations in that study um, from looking at body mass index, genetic mutations, and clinical presentation to see how those impacted onset of puberty. Body mass index, interestingly, overweight was equal or correlated to earlier. The B2 and PH2 stand for Tanner 2 for breast and pubic hair. And so overweight correlated with an earlier Tanner 2 breast and pubic hair. Normal or underweight correlated with a later Tanner breast 2 um, um, and pubic hair as well, but had no impact on menarche. Mutations, milder mutations correlated with an earlier menarche. More severe mutations, and these are, as have been described in the literature, as being more severe or milder mutations. More severe mutations correlated with the later menarche. But mutations seem to have no impact on either or when breast and pubic hair Tanner 2 was achieved. Clinical presentation is what is determined by using the clinical severity scores that have been standardized for Rett syndrome and are done all the time in clinic, either and certainly for the natural history study. Milder. So we have a standardized way of determining whether who has a milder clinical presentation, and the milder or a more severe presentation. The milder presentation correlated with earlier Tanner 2 breasts and menarche, but seemed to have no effect in our group in pubic hair. So males are also put on Tanner's in a category of categorized in Tanner stages. With males, it has to do with testicular size and penile size and pubic hair. So pre-puberty is Tanner 1. At Tanner 2, pubic hair begins to appear and testicles begin to show some growth. At Tanner 3, there's penile growth, pubic hair is coarsening, and then there's some other secondary characteristics such as voice changes and muscle growth and definition. Again, in Tanner 4, their pubic hair is changing, becoming more coarse, penile growth continues, and you begin to see armpit hair at Tanner 4. And then Tanner 5 is full adult maturity. So Tanner 2, puberty begins around age 11 in norms, the normal data, but unfortunately we don't know what the normal patterns of development are in Rett syndrome. We've got work to do. So the next thing we'll talk about is or I want to talk about is menstrual suppression. So, why would someone choose to suppress a period? Well, first off, there's no anatomical or physiologic reason to have a period unless you're going to have children. So, it impacts quality of life for many, uncomfortable, embarrassing for some, um, and just really affects quality of life. Seizures sometimes worsen, and I'll show a series of slides later on that explain that in some detail. Hygiene is a problem for some and is embarrassing if someone's in school. You know, adolescents can be pretty, pretty difficult when it comes to making fun of things that are normal. So that's a reason that some people choose suppression. Safety certainly is a reason because not only are you suppressing a period, you're also providing birth control, and then convenience. And don't underestimate convenience. There's nothing heroic about having a period. It's okay to choose to suppress simply because it is more convenient for everybody. So, options for suppression can be broken down into hormonal options or methods such as pills, patches, injections, implants, IUDs, intrauterine devices, surgical options such as hysterectomies or endometrial ablation, or what I call the NADA option, no intervention at all. You can choose certainly not to do anything to suppress a period. May not need to be, may not want to be. And certainly that is, don't let anybody tell you that you have to if that's not something that you feel good about. Um, But when you are ready, once it's time to decide what you're going to do, what if you're going to do, then that's the time that you need to call in the cavalry, as I say, whether that's an adolescent or adult gynecologist or a good primary care physician or practitioner certainly can answer your questions ahead of time, can give you guidance on what are your options. But sometimes some people in the community, physicians or practitioners in the community, don't know um, uh, some of the characteristics of Rett syndrome that would make one choice better than another. And so that's why it's really important, even though you may not be at a point that you need to think about a suppression option. I want you to know what the issues are so that you can be informed and can say, nope, you know, I really don't think that would be a good option for us. Can we try blah blah blah? Because it's they just don't understand some of the things that you face. As is true with everything and many things in life, timing is everything. And in this case, it's also true. We don't want to stop or suppress periods before they've begun. You know, I had forgotten this until I was thinking through what I was going to say today. And there was a conversation in California. Uh, I remember it was some physician or some family in California that was considering probably 20 years ago surgery to stop periods preemptively. So hysterectomies or in a pre-adolescent, and to me that was just horribly unethical to do that for a lot of reasons. But certainly we would not want to suppress premenarchal um, we don't want premenarchal suppression but you certainly can discuss the options before, and you should. think about and discuss the options when you know things are close. By allowing menarche to occur naturally, normal anatomy is confirmed, and you might say, well, how does that happen? Well, there are rare instances where there's an imperforate cervix, so the lining of the uterus um, um, develops just like it should. It sloughs like it should when the time comes, but there's no way it can escape the uterus. And so what happens? She looks like she's should be having a period. Um, Time is right for her to have a period. It's cyclic, but nothing is expelled from the body. So it's rare, but we want to make sure the anatomy not only of well all of the whole reproductive system is working like it should. We want full stature to be obtained. So going back to that example I gave you of the extreme of let's stop this even before she's had a chance to enter puberty, she's going to be the same size then that she would have been as a 6 or 7 year old. And that's not normal. That's not a good thing either. We know that the maturation process is completed, and that is how it should be. And it allows parents time to determine their ability to cope with menses. It may not be anything that you even have to deal with, particularly in the first 2 to 5 years when things can be very irregular. Um, it may never cause her problems. You may never have to suppress, but it's by letting the process and the process develop as it should. It gives everybody time to confirm what's going on and what needs to happen. And let me say, going back to this slide, what you decide at age um, 13 or 14 may not be what you can decide at age 18 or 25. It's okay to change your mind. Other than one option, everything can be changed. You can change your mind. So, how does there are many methods that we're going to talk about to suppress menstruation, and most of them use estrogen or progestin, which are hormones, the same hormones that are made by the ovaries, but they um, are given at a steady dose, and they are manufactured, if you will, but they are estradiol is what's made by the ovaries, and progesterone by as well. And so, when they are chemically given, it's progestin and progestin, estrogen and progestin. So, how do they work? They prevent ovulation. They thin the uterine or the endometrial lining. They reduce cramping and ovulation pain. They have a bonus effect of reducing the risk of some cancers, ovarian, colon, and endometrial cancers. But complete suppression may not occur immediately or at all, just depends. Everyone is different. So the next several slides are going through the different options and giving just a little bit of information about how they're given and some pros and cons and how we rate them in terms of something that we would recommend. So, excuse me, the oldest and probably best known method of oral contraceptive, which slash suppresses menstruation, is the combination oral contraceptive. And it's just as the name implies, it's a combination of estrogen and progestin. And this is the birth control pill that's been around since I think the 50s. They're given daily and may be given continuously. There is no reason that you have to come off every month or even every 3 months and have whatever semblance of period that you're having. They are often given continuously now, and there's even a brand name that is packaged that way, and that's called Librel. Probably many more. That was the first one. Probably many more now that are brand name for that purpose. Um, if you're using a, just a regular pack that would have 3 weeks of active medication and a week of placebo, you would just throw away that week of placebo and start a new pack. So you need, I don't know, 14 packs instead of 12 packs in a year. So that the insurance companies used to give us, um, not us because we don't prescribe it as a neurology clinic, but we used to give people problems with that because they couldn't understand why they were um, having to pay for more than um, 12 packs, but they've sort of gotten they've gotten the message, and they don't give much problem with that anymore. They can be given orally or through a G tube, swallowed whole if it's a regular pill, but there's also a chewable version now. And there are many options meaning the same formulation but with just a different name, and maybe your insurance in the States. I know maybe that's not such a problem in Canada, but if insurance won't pay for amethyst, they may pay for Librel. So it's just a matter of finding that not only the name that the insurance will pay or that will be paid for or without um, uh, problem, but it's also there may be just slight changes or different, or there are slight changes and differences in formulation. So, as I say, it's an old Southern term: don't throw the baby out with the bathwater. If one doesn't work, then you need to have a really good communication back and forth with the physician or the practitioner to say, hey, this low estrogen is not working. She's having breakthrough bleeding, but can we try, one that's maybe low estrogen rather than low estrogen? And that I used to have a slide that showed just column after column of different types. So communication is key here, and just be sure to talk with the physician and say if things are not just as good as you want them to be. The pros to this is that periods are certainly predictable, light, less painful. Suppression is attainable, and for most part is not risky. The suppression certainly is not um, risky. There's a lower risk of uterine and ovarian cancer, although it does increase some breast, other cancers such as breast cancer. But the main point is this: any estrogen-based method is going to increase the risk of deep vein thrombosis or blood clots, and therefore is not an option for people who are non-ambulatory. So I put a plus or minus score here because it's very good for some people but not for others, depending on their ability to ambulate. The combination patch is exactly the same. It's estrogen and progestin. It's an adhesive patch that's changed every 21 days to get that full suppression. Whereas before you would take it off if you wanted to have a period, you'd take it off for a week and then reapply it after 7 days. But it's reapplied after 21 days. The pros are the same, the cons are the same. So it gets also a plus or minus score in terms of recommendation. So moving from the combination to just strictly progestin oral contraceptive, also known as the mini pill. It's an oral pill that works. When it works, it works. It's great for people who can't tolerate for some people who can't tolerate estrogen, but it is very finicky, and that means a lot of breakthrough bleeding if it's not given at exactly the same time of day. A deviation plus or minus an hour, plus an hour minus an hour probably wouldn't work, but wouldn't cause problems until the next day, because then you're moving up, but you still you have to give it at the same time of day in order to achieve um, your best chance at suppression. Um, the pros, there's no blood clot risk, as I said, it's safe for non-ambulatory use, but it can really have some mood swings. It's less effective for suppression, as I've just described, and it can cause significant weight gain. The mood swings can be quite uh, interesting, I guess is the best way to put that. So as I was doing some research for clinic, I was told in clinic actually that there's an over-the-counter access to birth control, and here there's a pill that you can buy from Amazon of all places called O-pill. That's a progesterone only medication. And so I thought, oh, well, that's nice. I bet they offer that all over the world. Um, Sorry, folks, not in Canada. Or maybe that's good, because maybe that means that they're getting some really good advice about what to use. Regardless, the light orange is where you have to have a prescription to be able to access over the birth control, and it's not offered over the counter. I just thought this was interesting to show. So moving from the oral medications to those other methods of delivery. And the first one we'll talk about is the hormone-containing IUD, intrauterine device. And I stress hormone-containing because there's also a copper, an IUD that secretes copper, and it works by um, an immune response actually, that keeps the sperm from, it's a birth control method more than anything, when it's a copper IUD. But with the hormone containing and secreting IUD, you do get some suppression, and actually I know of someone, one of our patients, who's a gynecologist, and the family just talked about it and decided this was the best option for her because she couldn't take estrogen, and didn't want to take a daily pill. So she had an IUD placed. It is placed in, as it says, in her uterine, so in the uterus, under sedation. Stays in place a long time, anywhere from 3 to 8 years. It stays in place longer than many things can, other options, and it does lessen cramping. It's safe for non-ambulatory use because it doesn't contain estrogen. It's a second generation progestin medication. There are some cons. There's some breakthrough bleeding early on. It has to be inserted and removed by a clinician, and there it does increase the chances of pelvic infections, but fairly rare. An implant is also a progestin derivative medication hormone. It is a rod that's placed in the forearm, um, or upper arm rather, and implanted and removed by a provider, a professional. These can stay in place up to 3 years, which is a pro. That's an advantage. It also contains no estrogen, so can be used for non-ambulatory. The cons, though, alone, It only, and I say alone because I have a different strategy that's been used here at UAB that I'll talk about in a bit. But uh, implanted alone, there's only a 1 in 5, only 1 in 5 achieve total suppression. There can be mood swings, weight gain, depression, um, or depressed mood. I wouldn't characterize it necessarily as full-blown depression, headache, acne, and ovarian cysts. This is um, this is becoming a much more popular option for those in our practice who are wheelchair dependent. Um, the next non-surgical and non-oral option is injection, and that's such as I don't know what it's called in Canada, but it's called Depo-Provera, which is medroxy progesterone. Um, and that is an injection that's given every 3 months by a clinician, and sometimes it's a nurse, sometimes it's a physician. It is an old method. It is used a lot and recommended a lot by clinicians out in the community who don't necessarily understand some of the comorbidities that we see in Rett syndrome, particularly with bone density. And so this is the method that I alluded to earlier when I said I want you to be aware of things, because you may still run across clinicians, maybe not so much in Canada, but um, we do here, that uh, where an old, and I can say that because I have white hair, but an old clinician that says, "Oh, I've used this for years. This is no, this is great." And you don't have to take a pill every day. You don't have to have surgery. You just have to come to the office every 3 months. But uh, it can have significant effects on weight gain. I mean, like tremendously. So, I mean, because of appetite, it just goes through the roof and for many people. Mood and behavior changes that are significant. Um, Interesting blood clots can also occur. I didn't realize that and I don't know what the incidence is compared to estrogen. Breast cancers are also a disadvantage, but mainly it's the effect on bone density that we just really have a problem with. Although, if you think about taking a pill or having an implant or an IUD that can be maybe not reversed easily, but certainly reversed with minimal problem. If there are if after a depot shot you have, horrible behavior issues, and I've seen it happen. I've heard of it happening. I mean, it's the mechanism of action is that it works for 3 months, so you have to just wait for the bad effects to wear off. Uh, and that's if you don't worry about bone density, that's a reason to also be concerned. So for that, we put a big old X in recommendations for it. And in fact, the Canadian government issued their own, this is an abbreviated list of their warnings and precautions about medroxy progesterone, and that is because of the bone density risk. Um, and the opinion cited in their recommendation document was that it's worse the longer you use the drug, the bone density risk. The effect on bones may not be reversed by stopping the drug, and that's of significance really in adolescents and young adults when they're really building those bones for later on in life. Um, so their recommendations are to only use when no other treatment will work, and to use it for the shortest amount of time possible. So, what is the option when estrogen is contraindicated? So, um, and on this slide, I'm like, okay, I've just said don't use Depo, don't use Depo, but an alternative is a short-term use of Depo. So 2 to 3 um, cycles of Depo-Provera, followed by an implant. Remember, the implant only has only 1 in 5 achieve maximum suppression with the implant alone, but with this short cycles, 1 or 2 limited cycles of Depo, followed by an implant, gives us optimized suppression. And this is something that we've used in our most fragile, wheelchair dependent um, uh, young women with who needed something to for not only the convenience but also because of seizures and all the other reasons that a family chooses to suppress menstruation. Again, complete suppression. It's setting. This slide is meant to set your expectations at a realistic level and keep the communication open, because complete suppression for medications may not be realistic. Certainly may not on the first try, but it is something to to work with toward. So now we'll transition to the surgical methods for suppression. And this is the ultimate menstrual suppression, and that's the hysterectomy. Everybody knows what that is, but they may not be aware that the extent of anatomy that's removed with a hysterectomy may vary, and vary sometimes based, or almost always based on the what your goal is, the reason for the hysterectomy to begin with. If it's a problem with ovaries, then they may take just the ovaries. If it's, a problem with endometriosis or excessive bleeding, or to achieve or cancers of whatever part of the anatomy, they'll gauge how much to remove based on what the goal is. Um, I do want to point out, though, if you are considering a hysterectomy for to improve seizures, if everything else has failed, and you really know that seizures worsen with hormone fluctuations, you're not going to achieve that goal of lessening um, seizures from or catamenial epilepsy without removing the ovaries. So, because that is the part of the anatomy that makes the hormones that causes the fluctuations that cause catamenial epilepsy. And I have a diagram of that later on. We'll talk more about it. So, hysterectomies are surgeries, no matter whether you do a abdominal approach, a laparoscopic approach, a vaginal approach. It is it is used when permanent sterilization is recommended because it is not reversible. The cons are it's being major surgery. Then you have the risks of recovery from surgery. A deep vein thrombosis risk increases from the time that you're immobile in bed trying to recover. And there are certainly legal implications. Whereas before, in this country at least, you could, um, if you knew your surgeon, you could kind of say, okay, we've exhausted everything else. She's going into a situation where we feel like sterilization is the safest thing for her, and you might get it through. Now, with good reason, it takes at least an audience with the legal system to make sure that it is the right choice, and it's a thoughtful choice that is being made, and not just something that is not in her best interest. So that can be expensive. And for this reason, the pros and the cons, it's a good option for some people, depending on what the option or what else has been exhausted, but it's also the risks of from surgery. And then the last method we're going to talk about is endometrial ablation. And ablation is a surgical option whereby the lining of the uterus, which is called the endometrium, is purposefully destroyed by either laser or heat or freezing or radio waves. And um, so it destroys. How it works is, as for it for birth control as well as for menstrual management, is that it destroys the lining that ordinarily would slough, or that would support an egg. So that's why it's used as a birth control method. It's either an inpatient or an outpatient procedure, but I understand from others that have gone through it, outpatient, it is extremely painful, and they would, in that case, it would only be, the humane way would be inpatient under general anesthesia. The pros is that there's short recovery because there's no incision. Uh, the tools, whether it's a wand or whatever mechanism that is used for destroying that lining, is passed through the vagina, in the vagina, through the cervix, and then into the uterus to do whatever it's set out to do. Um, it's not effective for heavy bleeding. So some of the young endometrium um, is quite robust and healthy, and it's more effective for bleeding suppression in someone who is older, that is where the lining is thinner. Um, I've talked about the painfulness of it. Um, I had the honor of being at a conference at Harvard a few years ago, talking about this. The entire conference was about um, puberty and management, and in normal, quote, normal adolescents and those with developmental delays. And their opinion was the risk. The gynecologist and adolescent gynecologist opinions were that the risk benefit ratio is skewed far to the risk side. Um, in their opinion, they'd seen uterine wall perforations, and we're talking, this was a conference on adolescent um, uh, management. And so uterine wall perforations from the laser or from the implement itself, the tool itself, burns from the laser or from the water, scar tissue that would be a result of the burns, that would make any future um, procedure that would into the uterus more risky, because things would not be in the same, look the same, and act the same as a healthy, unscarred uterus. And then there is fluid introduced if it's using heat through hot water, and it's actually some of that fluid is absorbed, and there can be uh, uh, electrolyte imbalances as a result. So because of these things, we recommend in our clinic, and that this not be an option, and it's pretty much not used anymore in any population. Much literature has been written about it in adolescence, and it's just not recommended. So now let's talk about hormones and seizures and epileptic anti-epileptic medications and the relationships that we can see between these. So, um, sex hormones, uh, being estrogen and progesterone, have an influence on brain cells. Specifically, estrogen is neuroexcitatory and has a neuroexcitatory effect on brain cells, and progesterone has a neuroinhibitory effect on brain cells. And seizures associated with ovulation or menstruation are called catamenial seizures or catamenial epilepsy. And this type of seizure is caused by hormone fluctuations. So, can we predict seizures based on fluctuating hormones? And this very nice diagram shows everything that's going on in the body from through the 30-day cycle that a woman goes through, with day zero on the far left, as menstruation uh, finishes up, and then entering ovulation at day 14, and then menses beginning again along the bottom about 28 to 30 days. So I'm not going to go over all of this, but it shows the differences in the ovaries at the top. Body temperature fluctuates throughout the month. Um, and basal, that's anyone that's trying to get pregnant, you have to take your basal temp so that you can know by increase in temperature when ovulation is occurring. I think they have more sophisticated things than that, but that's what I did when I was trying to get pregnant with my girls. The anterior pituitary hormones um, are produced in the pituitary in the brain, and then in green, I'm sorry, in purple and in gold are uh, the diagram of what's happening with the ovarian hormones, estradiol or estrogen, if in the chemical form, or progesterone in purple. And so remembering that estrogen or estradiol is neuroexcitatory, we see a peak here at day 12 to 14. So that might be a time that you see an uptick in seizures right before ovulation. Likewise, remembering that progesterone is neuroinhibitory, it's falling rapidly at about day 24 to 28. So that may be another time um, in the course of a cycle that you see an uptick in seizures. And so keeping diaries about seizure frequency as it relates to other things going on that you see. Um, does she act like she's in pain around 14 days, which you might say that's around ovulation, and she really had an uptick in seizures at that point? Then that would be important information for the neurologist and maybe the adolescent gynecologist if they are conferring to know. Or is it more right before she starts her period that you see this uptick? So these trends are in a normal cycle where things are regular, if you will, then it's you may well be able to predict um, when things are happening, and either treat them by suppression, by evening out those hormones by some um, extraneous method that we've just talked about, so that you don't get those huge um, uh, uh, fluctuations of estradiol or progesterone. You may see better seizure control. Or it may be that the neurologist decides that they want to treat something that is a seizure that's really not a problem except at that day, 2 week period time frame, or near the menses. And they may treat with something just as needed, either a little clonazepam or maybe just increase the seizure med for those times that can be anticipated. There are also relationships or interactions between estrogen and some anti-epileptic medication. So estrogen um, decreases levels of lamotrigine. So if you've been rocking along and with good seizure control with lamotrigine, which is a really common and well-loved seizure medicine in here with us, because it is there's no lab work that really needs to be done. But if it's been rocking along, everything's been going well until estrogen is introduced, and all of a sudden seizures are not so well controlled. Well, it may be that estrogen's effect on that it's having on lamotrigine. And so what can you do about that? Well, you can increase the lamotrigine as long as the estrogen is at a steady state. So in other words, that's another argument for keeping um, uh, continuously giving whatever suppression, uh, estrogen based suppression you're using, rather than coming off at some interval, because then you run the risk of, well, you've taken away the estrogen for that week, and now the lamotrigine may become toxic because we don't have that effect anymore. So that's a argument that we use quite often in um, in talking about these things in clinic. Um, Likewise, estrogen increases levels of phenytoin. It's an old seizure drug, maybe not one that's used worldwide. We still have a few people that take it. So you would get there's a potential for toxicity if once estrogen has been introduced. So what you want to do is monitor drug levels right before starting estrogen, and then after being on a week or two to make sure that things are not becoming toxic. Estrogen has no effect, though, on valproate or carbamazepine. Um, Flipping the coin, anti-epileptic medications can have effects on combination oral contraceptives. Specifically, these listed carbamazepine, oxcarbazepine, phenytoin, topiramate, phenobarb, um, primidone can break down or increase the breakdown of oral contraceptives, making them less effective. So what are you going to see? You're going to see more breakthrough bleeding, perhaps. Um, and so you may have to have a little bit more estrogen. Again, conversation to have with the prescribers of, and if neurologists and gynecologists would talk, that's even better. Anti-epileptics have no effect. These um, anti-epileptics, valproate, lamotrigine, Keppra, felbamate, gabapentin, Gabatril have no effect on oral contraceptives, so you won't have that same risk of breakthrough bleeding. Um, let's jump into health maintenance, so gynecological and breast health in our last time to talk. So women with disabilities face barriers to care that can impact and do impact health and ultimate survival. And why is that? Well, they're physical barriers. So um, the table is too high, and nobody's willing to pick her up from the wheelchair and or can put her up on the table. Um, Specula are too big. I mean, these are physical barriers. Aging caregivers. Uh, it's just, the woman who is with Rett syndrome, who is 50 or 60, has parents we'll have parents who are, you know, 70 or 80. And that's very difficult to think about, not only just being aware that there is an issue with health, but also how am I going to get her there? How am I going to get her up, you know, does she have to have a mammogram? Can I get her up on the table? What are my options? Um, Misunderstanding the risks, and we'll talk some about that in a bit. I think sometimes it's easier just to you've gotten through life and you've gotten through what you think is the difficult years of um, early Rett syndrome, but there are personal risks that have to be considered far into adulthood. And then the final barrier, in my opinion, or the final that I'll talk about, is unsure provider. Someone who doesn't understand developmental disorders, isn't willing to learn, won't moderate or um, modify what their plan is. They're going to, do it this way or no way. So these are all things that make health um, maintenance a problem. So we can't talk about gynecological things without talking about pelvic exams and tests. And uh, some people don't understand or really haven't thought to differentiate the difference in a pelvic exam and a test like a pap smear or an HPV test. So a pelvic exam is just that. It's an exam that checks the health of reproductive organs in the pelvis by physical exam, and and the level of physical exam can be variable. It can be, a hands-on examination. It might be um, an imaging examination, but it is just that. It's an exam. A pap test, pap smear, is a test um, that specifically tests or detects cancer or precancer cell changes from scrapings of the cervix. Um, and Cervical cancer is caused by um, um, a virus called human papillomavirus. Um, there's a vaccine against that now given to adolescent girls and boys, I think, but certainly girls. I only had girls, so I don't really know, but I think they give it to boys as well because HPV can affect other than just sex organs. But it's a test that directly checks for the presence the virus that makes a cervical cancer um, um, more prevalent or increases the risk for cervical cancer. And it's a virus that is introduced through sexual contact, intercourse. So, um, but then you need to weigh, or we do, the necessity for a pelvic exam in an asymptomatic individual. And so to do or not to do. And that is the question in the US, but not in Canada. You guys are so good. Your task force for preventative care um, came out with an unequivocal recommendation. In asymptomatic females, a pelvic exam is not recommended for any screening of non-surgical cancer, pelvic PID, inflammatory disease, or any other condition, as long as the individual is asymptomatic. But all bets are off. If the individual is symptomatic, then certainly a pelvic exam is warranted. And since I mentioned pap smears and HPV tests, you may know already, but in Canada, the pap smear as the gold standard or recommended test was phased out and replaced completely by the HPV test as being a more accurate uh, indicator of risk for developing cervical cancer. But again, your task force in Canada recommends against having an HPV test in a non-sexually active woman. But the rub comes in when exposure is non-consensual. So you always have to put that in the back of your mind that uh, what she's been exposed to through other mechanisms. And just to let you know, this is, the U.S. we can't agree on anything anymore. And so every group professional organization that I've listed here, came out with just a slightly different or quite different recommendations for asymptomatic testing in women. I tend to like the one from ACOG, which is the first one, because it talks about a conversation between the provider and the family, weighing risks, and then deciding when there has been a good conversation, um, whether or not an asymptomatic pelvic exam is necessary. So, is it necessary to do a pelvic when starting menstrual suppression? Only if you're doing if IUD, an intrauterine device, is the method of choice. Should a pelvic exam be done when there is a change from norm, such as a discharge, new bleeding, no onset of periods, or if there's a question of abuse? You bet, absolutely. There are some tips. Some of these are common sense. Some are not necessarily ones I would have thought about without doing some research. The first one is assembling a good team. Make sure that the team of practitioners is listens to you, is sensitive to your concerns, sensitive to your daughter, not just talking over her head, but talking to her, understanding that why her expressive language may not be perfect, her receptive language may be spot on. Education and preparations, and that means um, uh, teaching the clinician about Rett syndrome. I wouldn't walk in with the handbook, but I would certainly, give them your 5 or 10 minute spiel about what Rett syndrome is all about, but also educating your daughter about what to expect. Don't ignore that she doesn't need to be prepared. Sedatives, and those are for her, not you. Although you might you might can use them too, and it might make everything go better. But certainly, I would not think of doing a pelvic exam without some sort of sedative on board, just to make things more relaxed and easy to do. Not to mention, no use putting her through undue anxiety. Not all pelvic exams have to be done on your back in stirrups. There are other methods such as side lying and not everything has to be done with a speculum. Some things can be done just with a manual technique. Um, Specula come in different sizes, so one that might be used for a 200-pound woman shouldn't be used with someone who is the size of a 15-year-old or 10-year-old. So make sure that everyone is aware that she's small and that if it's not a practice that's used to seeing adolescents, maybe they need to get in some adolescent sized equipment. You need to understand the necessity because sometimes when it needs to be done, it needs to be done, and sometimes that makes it easier to accept. And when you know that there's a good reason. You need to control your anxiety. Um, Go back to using the sedatives. Um, and then piggybacking potentially onto another procedure. If she's going in for a VNS, revamp, or a dental procedure where there's going to be conscious sedation, maybe that's the time, if you have the luxury of timing, that you can piggyback that on so that um, it's a more relaxed situation. Um, Moving on to breast health, there are some common risk factors to uh, developing breast cancer. Um, if you're older, there's a greater risk than if you're younger. There's a race component. Caucasians have a higher risk factor than African Americans. Um, Genetics, I'm sure everyone knows that there is a genetic predisposition, a specific mutation called the BRCA mutation. So if you know that is in your family, or if you don't know, if gene testing hasn't been done, but you know, 5 generations back, and there every time for every generation there's been an incidence of breast cancer, then maybe that is that will tell you more than just having to have the gene test done. Gender, of course, males can get breast cancer. Certainly, females, it's more common. Um, Age of menarche, those who start their periods before age 12 have a higher risk than those who began menarche or went through menarche after 12. If you're on oral contraceptives, estrogen based, or uh, um, hormone replacement therapy after menopause, then that increases your chance of breast cancer. Age of menopause after age 55. Um, if you are older than 55, then that increases your risk as well. And then if there's a previous history in yourself of having breast cancer, then that increases your risk for a further incidence. So let's look at the what I just went through, and some of that, and also things that are specific to Rett syndrome that might make that an extra risk factor. So female gender, check. Early menstruation, sometimes, check. Never having children, check. And then physical inactivity, check. These are all special risk factors or other risk factors that have been associated with uh, uh, breast cancer risk. And so it's not to frighten anybody, but certainly it's just to keep it in your mind that these are things that you need to consider as your daughter ages. Observation is always the first line for screening when with breast health, and I cringe to think um, about um, relying only on a mammogram, particularly with someone who might not understand exactly why this is going on, and you don't want to wait if any of these things are things that you notice and you do notice them, then you need to bring them, excuse me, to the attention of her physician or um, provide care provider. Um, but these are things that you can easily notice if they're there, such as we hear about self exams all the time, and we just need to do a better job doing them for ourselves, but also for her. Um, so feeling any changes to the breast or underarm area. If you notice swelling or warmth or redness or color changes, the size and the shape of the breast may change if there's something going on. There may be skin changes, uh, dimpling or puckering of the skin, or nipple changes such as um, uh, um, change in appearance, a rash or scaly sores, um, a discharge from the nipple, and then a discomfort or a pain in one spot that doesn't go away. And as you decide what to do with that information, um, or as you decide what to do for screening or for health maintenance, you need to know what the individual risks as you decide what your next steps should be and will be. Excuse me. There are alternatives to just your blank, run of the mill um, mammography, that torture uh, chamber that I hope everyone goes through as they're supposed to. But they're currently in use, approved, are ultrasounds if there's a problem, or if you feel like it warrants her history warrants a closer look. Ultrasonography, other imaging such as MRI, and then 3D mammography, which is um, I, that's that's what I have take advantage of here, and it is not as uncomfortable. Certainly, there's not the mashing between two plates, but you do have to hold a position and hold your breath at on command. So, but just know that these options are out there if the risk is warrants this. There is some limited use tools. It's not a primary tool yet, but digital breast thermography is sort of up and coming, but not used yet as a primary tool. Um, and um, Another thing on the horizon, or another alternative on the horizon but not yet approved, is molecular breast imaging, or MBI. So as we finish up, or as I finish up, I'm well aware that there's work left to be done. We certainly need male data, as we've identified more males with Rett syndrome or with MECP2 mutations. There's just not enough in North America to at this point to be able to have significance, but certainly worldwide, if we just need to put our heads together, because I think this is just as important information for families to have. Um, it may not have all the implications, but certainly they deserve to know what to expect as well. And then we need more older women normal data. We really don't know anything about menopause onset, well, really, age of onset is the major thing that we would like to know. And then, what are risk factors for cancers in our population of older women? Just a word on that. Uh, we did a survival study here at UAB, again using natural history study data, and at age 50, over 50% of women were with Rett syndrome were had survived, and we have a woman here that's my age that we follow, and one in Indiana that was in her 60s the first time we met her and made the diagnosis. So this is the issues of aging are um, ever more important, and we just need to do our due diligence. And thank you for hanging in there.
Jane, that was fantastic. Thank you so much for providing all that really valuable information to our community, and also gearing it to us Canadians and showing us the literature. And honestly, that's breaking news, like March 2025, that they changed. So that's fantastic. It's great that
Yeah.
um, yeah, that we have that information to share to our community. I guess we'll just open the floor up now to any questions if anybody has anything they would like to ask. I mean, people can think about it. I have a question I can start, and then you guys can think about if you have anything to ask. But um, going back to when your child starts menstruation and you're thinking about doing the birth control pill, they're also on seizure medication. Do you have, is there a suggested length of time you have to wait, like a year, to see how the periods are trending, or I don't know what the right word is, but to
Yeah.
see how
The
things are,
impact.
the impact, right? And before you can actually start an over-the-counter medication.
Um, so so in Canada you can't use over-the-counter medications.
Sorry,
Yep.
I said that incorrectly. Like a birth
Yes.
control or
Yes.
yeah,
Yes.
oral
So
contraceptive is what I was trying to say.
no, some people the only recommendation is to let that first period happen.
Mhm.
And then uh, some people are like, okay, I've done it. Let's stop it. And then some are like, that was not that bad. Let me just wait. So no, there is no standard as to how long is too long or how long is not long enough.
Perfect, thank you.
Mhm.
Everyone's saying thank you so much for the valuable information.
Oh, you're welcome.
Real data versus some of the anecdotes that were heard previously. Um, yeah, I'm not sure if anybody else has anything else to ask or any comments, questions before we let Jane go for dinner.
And if you're shy about asking, let me put my email um, in. It will be good for another month. But let's see. There. Yeah. Um, and then if you can always somebody always knows how to find me. Sabrina can get me.
Absolutely.
Yeah.
Oh, I think we got a question.
Yeah. Who should we get a referral for endocrine? Oh, who should we get a referral for, endocrine or gynecology? Onset of first period. So endocrine, if endocrine is only called in if a problem um, is considered. If things are going on just fine, then a gynecologist would handle it. If I'm understanding, Pooja, your question. Um, so if everything is moving along just fine, a gynecologist or a good primary can help you navigate what your options are for suppression. Um, if things aren't moving along and they're outside of the norm ages that I gave you, then I would talk to your primary and then endocrine would be the route way to go. The primary may well start some preliminary lab work. There's some things they can look at, um, or some imaging studies, but um, around here they usually refer or quick to refer to endocrine.
So I have a general question. And I know you kind of answered it, but just as a sort of wrap up, um, what would families have to ask, or maybe make a quick checklist of things to ask a gynecologist to make sure that they're sort of um, keeping in track with the changes in the body that are most linked towards the onset of puberty. Like what are like maybe the top three or four things like a family can remember to ask their gynecologist to say, okay, this is sort of what's progressing, and this is sort of the next stage.
So um, usually what when you go to see a gynecologist, it's usually either right before you suspect menstruation is going to start. So it's not something that you go at 10 or 2. They're more like 3, maybe 4, entering 4 when you go to a gynecologist. And so usually when you go to the gynecologist, what families need to ask are what are your options? What do you consider to be options for menstrual suppression? I mean, that's really, if everything is progressing, that's really the reason that someone goes to a gynecologist
Mhm.
here, with our with our practice. If things are abnormal, then you're not really asking questions from the family side. You're really giving information. I'm here because X, Y, or Z. So there's less questions in the beginning, um, or fewer questions on the family side. Um, our families in particular are well versed in what the options are for suppression. So I think that um, they are going to their gynecologist with already having made up their mind what they're asking for. Um, Now, occasionally, they get out, voted down because maybe because they're non-ambulatory, and then they have to look at other options of what to do. But it's not really, um, the questions are not really coming from the family at that point. Does that make sense, Beryl? I'm not sure that I answered it.
Yeah. Yeah, I think you answered that question. Thank you.
Um, they just don't go to the gynecologist just for kicks and giggles,
Yeah. It's
unless,
specifically
yeah,
for
Yeah,
purpose
yeah,
and within that age
yeah,
range.
definitely a referral from the primary caregiver
Yeah.
to the gynecologist for reasons, right? Yeah.
yeah, yeah, yeah. Unless they want to handle it themselves. And I would say, because in rural areas, the primary handles 99% of menstrual suppression management. It's only in medical centers, or where families have access to medical centers like out, big ones, that a gynecologist, and really it's really great when there's an adolescent gynecologist, because they get developmental disorders more because they've had training in pediatrics, many of them, and they just get it. They're into the size, um, uh, issues. They're not used to, they're they're not looking at. Sorry, it is so dry in the South. It's never dry in the South. We're usually raining off of the like um, rainforest, but my throat is very dry. Um, but yeah, it's it may be a primary care, it may be a gynecologist that helps you decide.
Gotcha.
Okay, going once. Just want to make sure that everyone's okay and comfortable before we exit off. Thank you all for joining. This was such a great event. I'm so glad that we got to record it and that we're going to put it on YouTube. So please, if you need to watch it again, the information will be there. I also maybe will ask Jane if she would like to, or if she could share the slides, if that's okay.
Oh, absolutely.
Yeah. Oh, that would be perfect too. And we can upload the slides this way everyone has the information
Yeah.
available. And also to thank again our sponsors, Acadia Pharmaceuticals, for helping us support Rett rounds for our community. So thank you all for coming. And Jane, it was a pleasure. Thank you so much.
Thank you for asking. I'm so honored.
Thank you, Jane.
Bye,
Thank you.
everyone. Have a good evening.
Bye.
Bye.